Hello everyone and welcome to another episode of Heart Success Podcast. This is episode 3 of 4 in our Cardio-Oncology series. Our topic of discussion today is arrhythmias in cardio-oncology, its diagnosis and management. In our episode today we have two guests, both cardio-oncologists. Our first guest is Dr. Michael Fradley. Dr. Fradley recently joined the Division of Cardiovascular Medicine at the Perelman School of Medicine and Penn Medicine in Philadelphia. At the time of recording this episode, he was at his previous academic position at the University of South Florida Moffitt Cancer Center, where he was Director of Cardio-Oncology and Associate Professor of Medicine in Cardiac Electrophysiology. Dr. Fradley graduated from the Johns Hopkins School of Medicine, following which he completed his residency in internal medicine through the Osler Medical Residency Program at the Johns Hopkins Hospital. He went on to complete fellowships in both cardiology and clinical cardiac electrophysiology at Massachusetts General Hospital in Boston. Dr. Fradley is a cardio-oncologist and an electrophysiologist. His clinical interests include the treatment and prevention of cardiovascular disease in cancer patients and survivors. He also has expertise in cardiac implantable devices and the management of heart rhythm disorders. His research focuses on all aspects of cardio-oncology and a particular interest in the diagnosis and management of arrhythmic complications associated with traditional and novel cancer therapies. Board certified in cardiovascular disease, clinical cardiac electrophysiology, and internal medicine. And like I mentioned, just a couple of months ago, took his role as the Medical Director of Cardio-Oncology Program and Associate Professor of Clinical Medicine at Penn Medicine, University of Pennsylvania in Philadelphia. Our second guest is a cardio-oncologist, Dr. Avirup Guha. Dr. Guha and I actually both trained at St. G.S. Medical College in Mumbai, India. Dr. Guha completed his internal medicine residency at Medical College of Georgia, following which he completed his cardiovascular disease fellowship at Ohio State University Hospital.
Dr. Guha is an assistant professor of cardiology at Case Western University Hospital. He is currently practicing general non-invasive cardiology in the community with community efforts for monitoring patients with cancer and heart disease. He is also nationally leading multi-center observational studies using large registries to study the epidemiology of cancer and heart disease. His specific interests include novel therapies for cardio-oncology-related toxicities, non-heart failure-related toxicities with cancer chemotherapy and radiation therapies.
I apologize for the quality of the audio of the actual recording of our interview due to issues with the platform we use to record it.
Welcome to Heart Success.
Thank you for having us.
So, Mike, tell us a little bit about you and what about cardio-oncology really drew your interest?
Yeah, so I am the director of the cardio-oncology program down here at the University of South Florida and Moffitt Cancer Center. And I've been doing this now for about 5 years. We started our program back in 2014. I started getting interested in cardio-oncology back during my electrophysiology fellowship. It's a little unusual to have someone who trained in electrophysiology doing cardio-oncology, but in reality, arrhythmias are a big problem for many cancer patients, and I was seeing that when I was doing consults on the EP service back in Boston, and that really piqued my interest. And that was a time when cardio-oncology was truly in its infancy, and I thought that this would be a really interesting opportunity to really be a part of something at the ground level and help to develop a specialty and really start to understand things at a more subtle level and take care of a group of individuals who really need highly specialized care.
Having cared for a few patients with heart disease and cancer, these patients are quite complex, and
the burden of arrhythmias and the challenges that come with managing these arrhythmias is certainly out there. So it's always great to have someone who has specialty in electrophysiology also be such an expert in cardio-oncology. It really helps us all understand this population a lot better.
Absolutely.
Any advice for trainees and people who want to get involved in cardio-oncology or consider training in cardio-oncology? As far as I'm aware, there were no ACGME accredited fellowships out there. But what's your advice for people who want to get involved in this aspect of cardiology more?
So I think that, immersing yourself in the field as much as possible is essential. So to whatever extent you can at your home institution, seek out experiences with the physicians that are doing cardio-oncology. Do rotations with those individuals, go to their clinics, and really take the opportunity to learn from them about these patients. If you can, do some advanced training and do a cardio-oncology fellowship, that will obviously make you the best prepared to go out and lead a program if that's what your interests are. I also recommend going to the various cardio-oncology meetings that exist. Again, this is a great opportunity to network with the leaders in the field and also really learn in a very intensive setting the most relevant areas of cardio-oncology. And there are multiple really well attended and well put together conferences, from the Global Cardio-Oncology Summit, which is really a very internationally driven affair, to the ACC Cardio-Oncology meeting that happens in the winter every year, as well as a conference put on by Memorial Sloan Kettering in the spring. So each of these can provide some really great education and training for fellows.
I'll direct the next question to you, Avirup. So I can barely keep up with the research going on in cardiology, let alone oncology. And we know oncology research is really proceeding at an unprecedented pace. So how do you keep up with all this information out there for people who are looking at this as a career?
I think this is a great question, and I think something that everybody who is trying to develop in this field is struggling with. But at the same time, I think it is a little fast-paced when it comes to keeping up with the cancer literature compared to the cardio-oncology literature, which is still relatively limited. So what I do is I obviously have the table of contents of not only the cardiac journals, but I also have the major oncology journal table of contents, which I get in my email. I go through it every week, sort of to scan through some of these articles which are about drugs which have known cardiotoxicity, and sort of look through them and look through the side effect section of them and see what was reported. And then additionally, the efforts of sort of working with leaders like Mike is helpful, because I got to participate in an article which he wrote on updates in cardio-oncology, which made me then go through like 3 to 4 years worth of published literature of FDA-approved drugs to see what toxicities out there of the novel therapies, which got me even more interested to read about this more and find out more. But I think this in general, keeping up with the new medications is challenging, and I think one more place where we all go to, and if you direct your efforts correctly without wasting too much time, I think Twitter is also a good source of getting information very quickly. And I'm also going to open this question to Dr. Fradley, because I think he must have a different strategy as well in dealing with all the information we get from the cancer colleagues.
Yeah, I think Avi, all of the recommendations that you just made are excellent. And I think the point that you made about Twitter is really a spectacular way to disseminate information quickly. So I find that to be a very useful way to quickly learn about some of the more interesting and novel areas in cardio-oncology. I also think that, again, a lot of it is immersing yourself amongst the right colleagues and practitioners. So if you can interact more with medical oncologists, go to some of the medical oncology tumor boards, where that will allow you to learn a little bit more about their thought process and some of the newer therapies that might be in pipeline, since a lot of the cases that are discussed at these tumor boards are the more challenging, more complex patients who may have already failed some of the more traditional, well-known cancer therapeutics. So that's really a great opportunity to learn and then to develop relationships with the oncologist who can also give you that guidance about where some of the shifting directions are in oncology.
And a lot of this has to do with the advances in cancer therapies. Cancer patient survival has significantly increased in recent years, and the clinical relevance of preventing and monitoring for cardiovascular complications as a result of these oncological therapies has become quite important. A lot of the focus has been directed to early detection and prevention of patients for heart failure as part of cardiotoxicity. But we know that the cardiovascular toxicities from these cancer therapies, including chemotherapy and radiation, goes beyond heart failure. So today we're going to focus a little bit more on the non-heart failure toxicities, mainly those being arrhythmias. So Mike, cancer and arrhythmias, is this a high burden of arrhythmias that we experience among patients currently being treated with cancer or those who have been treated in the past and have survived their cancers? Do we think about these arrhythmias differently compared to other cardiovascular patients?
That's a great question, and the answer is that the burden is quite high. So we know that the overall prevalence of atrial fibrillation and other arrhythmias is around 4 to 5% for all cancer patients, and then of course there are individual subtypes of cancer and specific therapeutics in which this incidence can be much, much higher. And the complications associated with atrial fibrillation are often more frequent or more pronounced in the cancer patient population. So higher rates of thromboembolism, higher mortality, higher heart failure as well. So this is something that needs to be really taken seriously in the cancer patient population. And ultimately, managing these patients, as you point out, is quite complicated and nuanced as it relates to risk of bleeding when we initiate anticoagulants, the association between different drug-drug interactions, both of the anticoagulants and some of the treatments for the arrhythmia itself. So this certainly is an area that requires a lot of thought and collaborative interactions between cardiologists, oncologists, electrophysiologists.
When we look at patients with atrial fibrillation in my office, in the cardiology office, when I'm looking at non-cancer patients, I commonly go back to the CHA2DS2-VASc score to look at their risk for thromboembolism. And sometimes I'll look at the HAS-BLED score as well to really assess patients that are high risk for bleeding. Can we use these scores among patients, among cancer patients with atrial fibrillation?
So that's a great question. And unfortunately, neither of those scores are particularly useful in the cancer patient population. Particularly the CHA2DS2-VASc score has been shown in various studies to have relatively poor predictive ability for thromboembolism risk in cancer patients. There was a very large study that suggested that patients who had a CHA2DS2-VASc score who also had cancer had a higher risk of thromboembolism compared to the general population. However, once they had a CHA2DS2-VASc score of 2 or higher, they actually had, very surprisingly, a lower risk of stroke and thromboembolism. And there's a lot of reasons why that might be the case, but I think it goes to show you that this score is really not adequate for the cancer patient population. And there's a lot of different competing risks that are going on, and we need to start developing research that can help ultimately guide and create a cancer-specific risk assessment tool. And the same thing holds for the HAS-BLED score, just not an adequate scoring system for cancer patients who have multiple different bleeding issues that are not included in that HAS-BLED.
That is so interesting, Mike. That means we can't really use the CHA2DS2-VASc or the HAS-BLED score in these patients.
So, Avirup, in your practice, how have you been making these decisions? And I'm sure a lot of it involves discussion with your patient and the oncologist. But have you been using any tools to guide your care?
I think I'm going to dovetail off what Dr. Fradley said. The codes are definitely not accurate. I think one major area where I've often faced challenges is when patients have active cancer, because they have a risk of bleeding from being on some of these agents, which is called thrombocytopenia. It's not accounted for very well in the current system. And whatever smaller core systems which have been done research on have not been validated in a large cancer cohort. So what you generally do is sort of a cardiac tumor board kind of situation where I calculate the cohort, I decide on single versus double therapy based on other indications, and then I don't prescribe these medications. I send a message of my plan to the cancer colleague. The cancer colleague then looks over my plan, decides what they are going to do next. So some of these patients might be undergoing surgery next. Some of these patients might be undergoing radiation next, or they might be going a combination of these plus minus chemotherapy. So they get back to me saying that it's okay to go ahead with the regular plan versus sometimes they say that no, we are planning a procedure and let's hold back on anticoagulation. So this is a little more anecdotal than you would like, but there's data behind one of this which I've studied closely by being a fellow at Ohio State, where we looked at patients with Ibrutinib. And we noticed that is a medicine which is known to cause arrhythmias way more than many of the other traditional cancer medications. And we noticed that a lot of it, even when the CHA2DS is high, doesn't cause stroke because a lot of these patients have thrombocytopenia. Now the reason is not very well defined or known, but it's very patient specific still, and we kind of feel it's lacking.
Clearly highlight the challenges with these really complicated patients and the side effects, like you mentioned, some of them thrombocytopenia, high bleeding risk that comes with chemotherapy. So one of the other questions I think that we commonly face in patients with atrial fibrillation is rate versus rhythm strategy, and I don't think we've established a clear winner, I think, in just your general AFib patients. But Mike, do you prefer a certain strategy in your cancer patients?
So again, this is an area that we don't have a lot of data to guide our decision making. And I think at least anecdotally, a lot of us believe that the pathophysiology behind the atrial fibrillation is probably a bit different than it is in the general population, and therefore the treatment and what they target may not be sufficient or adequate to effectively manage cancer patients. That being said, in the absence of that specific data, we have to apply the same general principles. So, I think a rate control strategy is optimal if the patient is asymptomatic and doesn't have other issues that may be complicating their picture, like heart failure. And since bleeding is such a significant concern in many of these patients, and the ability to maintain adequate anticoagulation is something that needs to be considered, rate control sometimes is the safest approach. One thing to remember, though, is there's a lot of interactions with cytochrome P450 system and the non-dihydropyridine calcium channel blockers. So I'll often go with beta blockers over calcium channel blockers in these patients. As far as rhythm control is concerned, again, have to be very cognizant of the drug-drug interactions and recognize that the inflammatory milieu and, again, the mechanism behind the arrhythmogenesis may make them a bit less effective.
And, that brings us a part of the rhythm strategy that we've explored, especially in our cardiovascular patients, is using ablation, atrial fibrillation ablation. I know it hasn't really had a big role in the general population, maybe more so in heart failure patients. We have better data showing benefits with respect to outcomes. Are there any cancer patients that you would consider atrial fibrillation ablation?
Yeah, I would consider it in, patients who are symptomatic and refractory to the traditional therapy. However, I think that this is a situation in which You certainly have to have a frank conversation with the patients about expectations and the likelihood of success, and really the lack of data and knowledge about success rates and benefits of ablation in this patient population. And as long as the patients are aware that, when you quote the success rate of, say, 70%, that may not be applicable to their specific situation, and they're still interested in pursuing it, then I think it's reasonable to try.
Okay.
That's a great point about just bringing this conversation back to the patient, discussing what they want. Because a lot of these cancer patients have undergone so much, gone through so many procedures, they may not necessarily want to go through more procedures, especially when there's no clear benefit and they're asymptomatic from the standpoint of atrial fibrillation.
Let's say that there was a person that you weighed the risk-benefit and had that conversation about going for anticoagulation. Do you have a preference for using a certain agent? Historically, warfarin has, because of the drug-drug interaction, not been favored in patients with cancer. Do you go to heparin or Lovenox, or could you use our direct oral anticoagulants?
Yeah, that's a great question. There's an increasing body of literature that demonstrates efficacy and safety of the direct oral anticoagulants in patients with cancer. Now, the majority of these data are in the setting of venous thromboembolism, both treatment and prevention. And there is very little data specifically looking at the use of DOAC in the setting of cancer and AFib. But there is more and more of that data emerging. And so if you use that and also extrapolate the VTE data, I think that the use of DOAC is really where the field is moving, and it's really something that I utilize in my practice on a regular basis. So there's been some sub-studies of both Aristotle and Engage AFib that have suggested the benefits and the safety of apixaban and edoxaban. There's a very large market scan database study, I think, of about 16,000 patients with active cancer who were being treated with anticoagulants, and it showed that there was less bleeding with apixaban compared to warfarin, and the risk of ischemic stroke was similar for all of the different DOACs. However, you again have to be careful about those potential drug-drug interactions. The factor Xa inhibitors interact with cytochrome P450. The Bigatran interacts with P-glycoprotein. So once again, those have to be factored into your decision-making of it.
Yeah. And, another group of patients I'm sure that you encounter are patients with pre-existing atrial fibrillation that do develop cancer. And like you said, maybe part of these patients were in Aristotle and Engage AF. Does your strategy with managing atrial fibrillation in patients either being treated for cancer actively or develop cancer and are being considered for treatment, how do you manage or tackle atrial fibrillation in such cases?
That's a great question. I think I don't necessarily make too many changes to their regimen unless they are on an antiarrhythmic drug, which is clearly going to lead to challenges for the patient. If you know they're going to get started on something that has a lot of QT prolonging potential and they're already on difetilide, I might consider switching to a different antiarrhythmic drug. But for the most part, I try to maintain them on whatever treatment that they have already been on, if that's been efficacious for them. No point in reinventing the wheel unless we absolutely have to. I think that an area that is interesting and could be explored from a investigational standpoint would be in patients that have higher bleeding risk and higher stroke risk. And we know that they're likely to have issues with maintaining adequate platelets, etc., over the course of a prolonged therapeutic period. Would there be a role for things like a left atrial appendage occlusion device in these patients, even in a prophylactic fashion? Again, there's no data to guide that decision-making, but it's something interesting to consider.
No, absolutely. That's a very interesting avenue. In your experience, have you used that strategy in certain patients?
Admittedly, I have not at this point in time, although it is something that I have been thinking about more and more.
Yeah.
And the challenge obviously is that there's a need for at least short-term anticoagulation as well as the use of antiplatelets, and that often complicates the situation. But there's a new study that is starting to enroll called ASAP-2, which is looking at doing this left atrial appendage occlusion devices without the need for that bridging anticoagulation and antiplatelet therapy. So that might be something, the result of which would be very interesting for a cancer patient population.
Very interesting. I know we've been talking a lot about atrial fibrillation. What about some of these other arrhythmias like atrial flutter or atrial tachycardias? Are they more common in the cancer patients?
I think that they probably are also more common. A lot of times they get lumped together, especially flutter with fibrillation. So I think that those two certainly are going to be elevated. But we're also seeing a lot of these short bursts of atrial tachycardia as well. So I think all atrial arrhythmias, at least ones that are not necessarily re-entrants like AVNRT, the automatic foci, et cetera, are elevated in cancer patients.
Avirup, I'll direct this question to you, actually. One of the drugs you mentioned was Ibrutinib, which has a very high new incidence of atrial fibrillation. Are there any specific agents, any specific chemotherapy agents that increase your risk for atrial fibrillation more so compared to others?
Since we had mentioned Ibrutinib earlier, because obviously it caught everyone's attention and definitely is responsible for as much as in some publications, 34% of atrial fibrillation. With the OSU cohort, we found about 15 to 20% atrial fibrillation. The other agents which we need to be careful about are obviously older agents, a mechanism unknown obviously at this point. The main one that comes to my mind are melphalan, which is seen in relationship with use for stem cell therapy because you need to give chemo prior to stem cell implant, and melphalan is commonly used. AFib is also noted with anthracycline, sometimes with 5-FU or 5-fluorouracil to be specific. And then the other agents which is seen with is other small molecule tyrosine kinase inhibitors like sunitinib, sorafenib, seen sometimes with rituxan as well. The other group of patients that comes to my mind who develop atrial fibrillation are the survivors of childhood cancers of non-Hodgkin's and Hodgkin's lymphoma who receive chest radiation, who develop fibrosis from the radiation, which is, as you know, neither for atrial fibrillation.
Thanks, Avirup. That was very comprehensive review of the different agents that are associated with high risk of atrial fibrillation. The other arrhythmic conversation that we have among cancer patients is the high prevalence of QT prolongation in this population and its association with arrhythmias. Do you commonly, Dr. Fradley, look at the QTc in these patients when you look at the EKG, and how do you interpret the QTc?
So there's a lot of attention that's paid to the QT interval with the various cancer therapeutics, and a lot of this is driven at the drug development stage and then, at phase 2, phase 3 studies. The problem is that we know that the QT interval is a relatively poor surrogate for the development of ventricular arrhythmias, and that the likelihood of developing torsades or other ventricular arrhythmias is really quite low, especially if the QT interval is less than 500 milliseconds. That being said, we're often forced to spend a lot of time looking at the QT interval because of drug labeling and such. It is certainly recommended that you avoid the Bizet correction formula when evaluating the QT and the QTc, and really focus on the Fidericia formula or perhaps the Hodges formula, although that is a bit more cumbersome. So the Fidericia formula tends to be a lot easier for people to understand and evaluate, and I would really advocate for using that in the overwhelming majority of circumstances.
I thought I'd break for a second to familiarize you with the different QTc formulas. One of the things you want to make sure is you want to measure the longest QT interval on your EKG. The Bizet formula is the one that's most commonly available on these automated QT readings on your EKGs.
Bazette formula is calculated as corrected QT equals QT divided by the square root of the RR cycle in seconds, or QT divided by the square root of the cardiac cycle in seconds. That's the one you don't want to use, but that's the one that's usually available on most automated EKG readings, so avoid that. The two he mentions that you want to use as alternatives, one is the Fradley formula, where the corrected QT equals QT divided by the third root of the RR cycle in seconds, or QT divided by the third root of the cardiac cycle in seconds. In Bazette, it was a square root in the denominator. Instead, in Fradley, it's the third root in the denominator. That's the only difference between the two formulas. The other one he mentioned was the Hodges formula. The corrected QT interval equals QT plus 1.75 in brackets heart rate minus 60. Another version of this formula is corrected QT equals QT plus 105 multiplied by, in brackets, 1 divided by RR cycle minus 1. This is definitely a little more complicated. I think it's easier and probably much better to just go to the Fradley formula, which I'll repeat was the corrected QT equals QT divided by third root of the RR cycle in seconds. So Mike, talking about QTc prolongation, any drugs that you can think of more likely to cause it than others?
We definitely see some degree of QT prolongation with various drugs, ranging from some of the tyrosine kinase inhibitors to ribociclib, which is one of the CDK4/6 inhibitor for breast cancer. But overall, the majority of these therapeutics can be delivered safely with appropriate risk mitigation strategies.
And do you commonly trend the QTc on your subsequent visits in these patients?
Only if the patient has had a change in their therapy of some sort. So, if they're escalating the dosage, or, they have developed renal dysfunction and the drug is cleared renally, or they're now on many other QT prolonging medications. But if things are stable for them, I'm generally not following it if they have reached steady state and their EKG looks okay.
Is there any evidence showing that even outside of just QTc prolongation, these patients, cancer patients, are at a high risk for either sudden cardiac death from ventricular arrhythmias or cardiovascular issues?
Certainly there is increasing data to suggest that some of these therapies can be associated with significant adverse outcomes, like increased cardiovascular mortality, sudden cardiac death. It's harder, I think, to quantitate the exact cause of these sudden cardiac death episodes. Were they truly arrhythmic, or were they related to some other potential toxicity? For example, the checkpoint inhibitors are associated with myocarditis. There is absolutely a connection with that and sudden cardiac death, but was it a malignant ventricular arrhythmia that led to their death? Was it pump failure? That's where it becomes a little bit less clear.
We've had a great conversation on the different arrhythmias and clear challenges that exist within this population and need for additional data. If you, maybe for our listeners, a lot of them who are telemedicine doctors and cardiologists, not necessarily seeing a lot of cancer patients, what would you recommend when they come across patients like this? Should they refer them to a cardio-oncologist, or is there any additional resources or help for these?
I think that if they have a cardio-oncologist as a resource, they should absolutely refer these patients and utilize them, because they are complicated and they do require a lot of nuanced management. And so I think this is a perfect situation to collaborate and partner with the cardio-oncologist to ensure that the patient receives optimal care. There are certainly resources that exist, various forms. There's multiple review articles. There are lots of sessions at different meetings that can give overall guidance. But I think that when you come across these patients that have cardiovascular issues and they're undergoing cancer therapy, having a cardio-oncologist engaged and involved is really ideal.
Absolutely. And what do you see as the future of the field?
First of all, I think that the future of the field is limitless. We're still really in a foundational stage of the field, and so we're still learning quite a bit. And also, the field follows oncology. So as oncology changes and evolves and paradigm shifts occur in the way in which cancer is understood and approached, so will cardio-oncology have to change and evolve. But I think that, some of the priorities that exist are really starting to understand fundamental biology of these cardiovascular complications. We have a lot of great studies defining the toxicities, but in order to better manage and treat and prevent these toxicities, we really have to understand them at a more molecular level. And also, I think that we need more data to guide our decision-making for both prevention and treatment strategies. There's a lot of expert opinion that exists that doesn't have a lot of foundation of data to support it. A lot of it makes sense, and there's no reason to think that it's not accurate, but we really should start having some of that hard data to support those expert consensus opinions.
Thank you, Mike, and thank you, Avirup, for accepting the invitation and for really this excellent discussion on arrhythmias in cardio-oncology. Really appreciate you taking this time to go over this complex topic.
Thank you, Mike.
Thank you.
Thank you so much for listening to the discussion. Hope you really enjoyed it. As a follow-up to our previous episode where we discussed radiation therapy in cancer, I will be spending the next 4 minutes discussing management of pacemakers and ICDs
among patients who are undergoing radiation therapy, either currently or will be undergoing radiation therapy in the future. Another fairly important finding is the increasingly common use of cardiovascular implantable electronic devices, such as pacemakers and defibrillators, in patients either with current cancer or patients who have been treated with cancer or shall receive future treatment. The devices pose unique challenges in patients receiving radiation therapy, especially if this device is in the direct radiation field, as is the case with many thoracic malignancies, be it lung or breast cancer. Now, the modern devices are relatively more tolerant of radiation therapy. They can still malfunction, defibrillators being more sensitive to these issues than pacemakers. Defibrillators are usually more sensitive to issues from radiation therapy than pacemakers. The most commonly observed effects or adverse effects from radiation therapies to these cardiovascular implantable electronic devices include increased pacing or sensing, device resets or safety mode revisions. Less frequent complications include early battery depletion, oversensing, pacing inhibition, complete device failure. Now, although the cumulative radiation dose can lead to CIED malfunction, a large majority of the complications really occur as a result of neutron production from high-energy beams greater than 10 MV. At these energy levels, even scattered radiation from beams directed a significant distance from the CIED can affect the functionality with device resets, loss of random access memory, and electromagnetic interference. In fact, a study from MD Anderson reported a 7% device malfunction in patients with CIEDs who were receiving radiation therapy at neutron-producing doses of more than 10 MV. Despite these findings, a majority of the patients can tolerate radiation therapy without complications. Despite the presence of reasonable evidence and recommendations for guidance, there is little standardization in the protocols across different centers. This is the result of changing technology, differing recommendations between different device manufacturers, and lack of communication between different members of the treatment team. In general, prior to radiation therapy, cumulative dose of the device should be estimated. And though there is no safe amount of radiation, cumulative radiation dose should not exceed 5 grays. The use of lower energy radiation therapy is also recommended. Shielding is not particularly helpful, and EKG monitoring may be recommended for high-risk patients, especially those who are pacemaker dependent. And tachytherapies should be disabled in the defibrillators when they're undergoing treatment. Another recommendation is regular in-person or remote interrogations performed during radiation therapy. Finally, if the device generator is directly in the field of radiation therapy, device repositioning should be considered
while taking into account the risks associated with the procedure.
At the end of the day, it is quite essential for cardio-oncologists and care providers out there dealing with patients with cardiovascular disorders and cancer disorders to get somewhat comfortable with these electrophysiological issues in order to provide best care available or the best care possible to patients with cancer.
So that brings us to the end of another episode that we had a great time creating. If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.